For our last video clip for Chapter 14, we're going to talk about HIV infection in a little bit more detail. So, as far as immunodeficiencies, this is probably the immunodeficiency you're going to be most likely to see during a clinical career. So, HIV is a virus, and it attaches to, you may remember we talked about HIV back in Chapter 5, and it attaches to CD4. That's its main host cell receptor. And CD4 is present on helper T cells. It's also present on some other cell types in the body, like macrophages and in the brain microglia. But the helper T cells are the main target of HIV. So this is kind of an interesting diagram here, which shows you what happens during the progression of an HIV infection. And notice the timeline over here is years. So HIV has a very long incubation period, and over here on our y-axis we've got two y-axes over here. Over here, this is going to be our CD4 positive T cell population, helper T cell population in the blood, and over here this is going to represent the number of copies of HIV virus in the bloodstream. Alright, so here's where you get infected, down here. And notice what happens with your CD4 positive T cell population. Right after you get infected, it drops, gets cut in half, maybe a little bit more in half, pretty quickly. So you get infected with HIV, HIV goes in those helper T cells, multiplies and spreads to other helper T cells, and your helper T cell population drops off. And then the blue line here is your HIV population. About 2 months after your initial infection, the HIV in your blood peaks. Okay, so you have a big surge increase in the number of those HIV particles in your bloodstream. But then notice it drops off. Okay, it drops off pretty quickly after that. In fact, it goes down pretty close to zero for a long period of time, for a period of potentially years. And so what's happened is you've undergone what's called seroconversion. That means you now have detectable antibodies against HIV. So your immune system does react to HIV. You do make antibodies to it. However, you don't completely clear out the HIV. It's not like other types of pathogens that you get exposed to where you have an immune response and it goes away. That just doesn't happen with HIV. You never completely clear it out. And notice as the HIV population drops, your helper T cell population comes back up. So you don't have as much of the virus around infecting new helper T cells, and your helper T cell population can recover. So now when all this is going on, people have like a flu-like symptoms because they do have a viral infection, so they've got inflammation going on within the body, and you're going to have some symptoms of that. But you know, it's not anything all that particularly dramatic. You might think you have the flu or something. It's probably, oh, hey, I've got an HIV infection. Is not going to really cross your mind. And as that HIV population drops off for a long period of time, for years, what happens is you just kind of have this gradual, slow decline in your helper T cell population. The HIV is replicating at fairly low levels, and just kind of gradually killing off those helper T cells. And eventually you get to the point where your T cell levels over here drop to about 200 per microliter of blood. That appears to be about the critical level where when it drops off below that level, you no longer have enough helper T cells to mount effective immune responses. And that's when you develop what we call AIDS, acquired immunodeficiency syndrome. You are now immunodeficient, and those patients wind up developing all kinds of crazy secondary infections. HIV is your primary infection. Secondary infections follow as a result of that first infection. So they start getting all kinds of infections with things that don't infect people with healthy immune systems. And as that happens, your CD4 positive helper T cells continue to drop off, almost down to zero. Your HIV levels start to come back up. And of course, if you are, you'll die. You'll die of these secondary infections if you're not being treated for HIV. So here are some pictures. So HIV patients often have these skin lesions, And this is actually a type of skin cancer called Kaposi's or Kaposi sarcoma. And so this is actually caused by a virus. It's been discovered not all that long ago, I don't think. It's a herpes virus relative that can trigger skin cells to become cancerous. And if you get that, it's called Kaposi sarcoma. Now, in all likelihood, we all get exposed to that virus all the time, but it's not a very good pathogen. If you have a normal, healthy immune system, your immune system is going to wipe that virus out before it can trigger the formation of skin cancer in you. So this is one of those oncogenic viruses that can trigger cancer. If you have AIDS, though, your immune system can't fight off that virus that triggers this type of cancer. So that's something that commonly develops in HIV patients. And that's also known as an indicator cancer because it's a type of cancer that generally doesn't happen in the regular population. It's occurring in these people who have AIDS. Another infection is a fungal pneumonia called pneumocystis pneumonia. So this is a tissue section in green, that's lung tissue, and these little things there that look like olives, those are pneumocystis fungi. It's a yeast. Multiplies in the lungs, causes a horrible pneumonia in the lungs, and this is also something that we all get exposed to all the time, but it's not a very good pathogen. If you have a healthy immune system, you're going to wipe this out before it ever causes you to feel sick. But in AIDS patients, their immune system isn't capable of eliminating it, and they can develop this pretty bad cases of pneumocystis pneumonia. So that's called an indicator infection because people with normal, healthy, functioning immune systems don't get pneumocystis pneumonia. It's something that if you have a patient with that in a medical setting, they almost always are an AIDS patient. So that's why it's considered to be an indicator infection. In fact, back in the 80s when HIV was first discovered, what was raising suspicions among physicians was that in Los Angeles, if I recall correctly, there were a number of people coming in with pneumocystis infections, and that was something you just didn't typically see very often. And then from there, things kind of snowballed, and they figured out that they had this acquired immunodeficiency syndrome, and eventually that was linked to HIV, human immunodeficiency virus. There have been no verified cases of a patient's own immune system completely eliminating HIV. So even though you make antibodies against it, they're just not effective at completely clearing it out. HIV is very good at going latent. Remember, it inserts its genome into the DNA of its host cells, so it can actually go latent and stay quiet, and it's almost impossible to eliminate. There have been a couple of cases reported in the news where people who underwent bone marrow transplants, so they took radiation and or chemo to kill their bone marrow, wiped out all their blood cells, that potentially could eliminate all of the host cells for HIV. But that's a pretty radical, and when you undergo the transplant, they're looking at trying to transplant bone marrow in that makes helper T cells that are not susceptible to infection. So maybe you can graft in donor T cells that would not be infected with HIV, and therefore that patient would become resistant to it. So that's something that people are looking at maybe as a strategy to treat HIV. The problem with that is undergoing a bone marrow transplant where you wipe out your existing bone marrow and replace it. That's a pretty harsh, severe treatment. And most HIV patients today do pretty well with an antiretroviral drug cocktail. Remember, HIV is a retrovirus. You take a cocktail of drugs, and if you take one drug for an HIV infection, HIV mutates pretty quickly and becomes resistant to it. But it's very difficult for the virus to simultaneously mutate and become resistant to multiple drugs. So typically in this country, AIDS patients who have good health care coverage are receiving injections of multiple antiretroviral drugs to keep their HIV infections dormant and under control. And they can, the life expectancy for those patients is pretty good. It's pretty close to normal human life expectancy. So you can live with HIV infection pretty well. And when you're being treated with that, your viral load, the amount of detectable virus in your body fluids, is extremely low. So those patients, also there's a pretty low risk of them transmitting HIV to other people as well. Unfortunately, in other parts of the world, these antiretroviral drugs are expensive and not as widely available, so it's still killing people in poor countries in other parts of the world. Okay, so here's this is a little graphic about HIV infections in the United States, new HIV infections in 2009 and how they were acquired. This is kind of an interesting graphic. So right now we have about 50,000 annual incidences. Remember, those are new cases each year in the United States. So that's still pretty bad, 50,000 new HIV infections. In spite of all that we know about the precautions you should take, the availability of these antiretroviral drugs, there are still people who get this. 61% acquire HIV through MSM, that's men having sex with other men. 27% through heterosexual contact. 3% are men having sex with other men and also intravenous drug users, so that maybe they don't know how it was transmitted. And 9% get it through intravenous drug use, sharing of needles. So that's kind of an overview of how HIV is transmitted in the United States these days. Okay, so this is a pie chart I wanted you guys to take a look at as well. Since most of you are planning to go into healthcare and you will potentially work with HIV-infected patients, what is the risk to you? It is extremely low. You are very unlikely to acquire HIV from a patient that you're working with. And in fact, ever since HIV came on the scene in the United States back in 1981, there have only been 57 confirmed cases of HIV transmitted to U.S. healthcare workers, and no new ones since 1999. I might need to double check that and just make sure there hasn't been one more recently, but last time I checked, there had been no new documented cases of healthcare workers acquiring HIV from a patient in 16 years. It's because you've got to follow those procedures and how you control HIV and make sure that it's not transmitted from patient to patient, or it's not transmitted from patient to healthcare workers. And proper handling and disposal of sharp instruments is the key. So I would imagine most of those cases, most of those 57 cases that occurred between 1981 and 1999 were due to needle sticks. So you're sticking a needle in an HIV positive patient, taking it out, and then accidentally sticking yourself with it. That's a great way to transmit HIV. So, within the last decade, 15 years or so, the rules about how you handle needles and other sharp instruments have really been tightened up. There are a lot more precautions today to help prevent those accidental needle sticks, which is a very good thing. Also, you have to use your proper barriers, as instructed when you're working with those HIV patients. But you don't have to worry about an HIV patient coughing on you and giving you HIV. It's just not transmitted that way. Lucky for us also, HIV does not survive outside the human body for very long. It inactivates pretty quickly. So that's why you don't really have to worry about HIV patients touching something and depositing HIV viruses on a surface that you're going to come into contact with. It just doesn't last out in the open environment for very long. That doesn't mean you can be casual about it. You can't. You got to follow all the rules and regulations about working with HIV patients. But lucky for us, it's not something that's transmitted all that easily. You've got to have some kind of body fluid to body fluid type contact. This pie chart, though, does show among the healthcare workers who did get HIV, it was transmitted in the workplace. 42% were nurses, 19% were lab workers. So nurses and lab workers made up the bulk. Notice only 10.5% were physicians, and then just a few numbers of people in other employment categories in the workplace. All right, so I just wanted to kind of discuss HIV in a little bit more detail, since that is such an important pathogen, and you will no doubt encounter AIDS patients during your work in healthcare. And so that's going to wrap up the immune system. So if you know the immune system is pretty complex, so you just have to kind of learn the vocabulary, and try to learn things for the most part as like a step-by-step story, and moving along from the first lines of defense to the second and to the third, and kind of learn those stories and how everything works together to help you fight off infections. So as always, if you have any questions, please post those over on the discussion board so that everybody can benefit from those discussions. And good luck, and let me know if you need any help.